go through some topographical anatomy, so just a physical examination of the limbs, what we're looking for, what we're seeing. So when I'm examining horses' legs, always start at the bottom, work our way up. We're putting hoof testers on first of all, appreciating the foot, and in the forelimb, 90% of lamenesses arise in the foot. And so we can see here, this is the frog just here. So if we have a little penetration just superficially into the frog, that's okay, it's just like going into our fingernail. If it goes deeper, this is into the sensitive tissue, this is the digital cushion. If we get a penetration into the digital cushion, we might well get an infection, we might have an abscess, the horse will go very lame, but we can deal with it. It's got a good prognosis. Whereas if that penetration goes a little bit further into the deep flexor tendon, which is this structure here, then we'll get a septic tendonitis. More likely than not, it will involve the navicular bursa, which is this structure just here. This is the navicular bone, this is the coffin bone. This is a little ligament, impar ligament, that attaches the navicular bone to the pedal bone. And then if the navicular bursa is involved, then that's serious, and that needs to be flushed out under general anaesthetic. And if it's left more than a couple of days, the prognosis gets very poor. This is just a foot X-ray showing a horse with laminitis, and with laminitis, the pedal bone rotates. So this front of the pedal bone should be parallel with the front of the hoof wall, which is here. And you can see how it's rotated around to the extent we've actually got a gas shadow within the foot. We've got air it's got into the hoof capsule, and that's what that black shadow is. And the pedal bone, you can see, is getting very close to the sole. So worst case scenario, the pedal bone rotates so much it can come out of the sole, which is very serious. So just a few landmarks. At the front of the foot here, this is the coffin joint, actually has an outpouching here. So we can palpate the coffin joint and feel whether there's any increased fluid in the coffin joint. And then we have the pastern joint just here at this level. And if I put the bone alongside, you can imagine where that would be. This is the pastern joint here on the bone specimen. That's the coffin joint. And when people talk about ring bone, that's when we see arthritis in this area here. So high ring bone would be changes in the pastern joint, low ring bone, changes in the coffin joint. And again, people talk about articular and non-articular ring bone, and articular ring bone will be actually arthritis within the joint. Non-articular ring bone, sometimes you get bone deposition just outside the joint capsule, so not actually causing arthritis. The next joint up is the fetlock joint, and the proper joint for that is metacarpophalangeal joint, just here. This is another fetlock X-ray, and this is a horse that's got some dark areas within the sesamoid bones, sesamoiditis, and that's often associated with suspensory injuries because the suspensory is inserting and attaching onto that bone, so often those changes go hand in hand. In terms of other structures that are important to feel, we have what we call the collateral cartilages. So attached onto the wings of the pedal bone here are some cartilage that help dissipate forces within the foot. And they are just here. And if you feel on your horse, you should feel a springiness there, and they're quite pliable. But you might have heard of side bone. Side bone is when those cartilage turn into bone, so they ossify, and then they become very firm and hard. This is an example of side bone. So normally, you don't see cartilage on X-rays, you can't see it, it's not dense at all. So there'd be cartilage just there. This is where the cartilage has turned into bone, and that's what side bone is, looking from front to back on a foot. And so these can snap off occasionally, cause lameness, but if they just ossified, you can feel that they're there, but they don't usually cause a problem. Their function is to dissipate force within the foot, so probably other structures are going to be more affected by the sort of concussion within the foot if these are ossified, but it seems to be age-related, breed-related, and probably biomechanics as well. So moving up the leg, in terms of soft tissue structures, we've got the fetlock joint here, so that has different pouches. So we can feel the fetlock joint at the front, so feel for any distension of that joint, if there's any arthritis or a sprain of the joint, there'll be increased fluid here. And then something that's really useful to remember that I'm going to tell you now, this structure here, has everyone felt this bit on their horse here? This is the lateral suspensory branch. So the suspensory ligament starts here, comes down, has the origin here, the body, and then it branches onto one side of the sesamoid, on here and on the other side. So it feels very hard, and sometimes people confuse that with, the vet students confuse that with the splint bone because it feels so solid when it's weight bearing. But these are actually the splint bones just here and here, which are a little bit further forward, just in there. So if you can recognise that as a suspensory branch, that's critical to understanding that in front of that, if you get swelling in front of that, that's the joint. That's the fetlock joint. If you get swelling behind that structure, just here, that's the tendon sheath. So that's what we call wingles. So when a horse has wingles, it's increased fluid within either the joint or the tendon sheath. And people talk about articular wingles, which obviously refer to the joint, and tendinous wingles, which refer to the tendon sheath. Now the tendon sheath is a structure that's a bit like a joint. It's got a synovial cavity and fluid in, just like joint. And it starts here, and it goes all the way down the back of the foot, back of the digit, all the way down to between the bulbs of the heels. And if that gets penetrated with a wound, if you have any laceration at the back of the pastern, potentially the tendon sheath is involved, and then that has to be flushed under general anaesthetics. It's very serious. You get an infection in there just like it is if you have a joint infection. So it's useful just to be aware of the tendon sheath. And lots of horses, particularly the hind limbs, will have slight wingles, and that's just within normal limits for that horse and just a bit of wear and tear. If they're very similar between left and right, that's fine. If there's more swelling in left compared to right or vice versa, then that's more of a concern that maybe there's actually some pathology rather than just sort of increased fluid that's not causing a problem. So yes, that's a useful structure to be able to identify. So this is an injured tendon here, so it should have this appearance here. This is the superficial flexor tendon that you just saw. This is the deep flexor tendon. This is the check ligament. This looks normal. This looks normal. Here we've got a big black hole that shouldn't be there. And then when we look at the fibre pattern, we see that we've got a loss of normal fibre pattern. It should all look like this, nice long linear fibres, and here we've just got a bit of a mush and a dark area, and it's just all essentially been eaten away and dissolved. And then we've got the cannon bone here. We have an extensor tendon that you'll feel down the front, it's a little tendon that comes down the front, but the tendons on the front of the leg aren't very critical. They're just used for placing the limb and extending the limb, but you can actually cut that completely and the horse will do fine. It will scar down and it won't even be lame, it'll all be fine, whereas if you lacerate these tendons, then the likelihood is that the horse will have to be put down, because it's very difficult to repair these tendons, almost impossible. Prognosis is very poor, other than possibly to be just about pasture sound. So all horses have splint bones, so these are the splint bones just here, but when we say a horse has a splint, that's when it has some new bone attached to that splint bone, so you'll feel a sort of knobbly bit of bone attached to it, and that occurs usually young horses coming into work, changes in biomechanics, a bit of tearing of the ligament that attaches the splint bone to the cannon bone can cause a bony reaction, new bone formation. It's essentially trying to stabilise the area biomechanically, or if the horse had a kick over a splint bone, that can also cause new bone formation. On the forelimbs, they occur more commonly on the inside than the outside, and the reason for that is if you look at the inside splint bone, it articulates entirely with this one carpal bone, whereas the outside splint bone articulates with the carpal bone above it, shares its force between the cannon bone and that splint bone, so you haven't got shearing down the ligament, whereas on this side you get more shear forces down that ligament because that one bone is pushing that on that splint bone. So that's why you get splints occurring on the inside on the forelimbs and not commonly on the outside. We do see them if the horse had a knock or something, but usually they're on the inside. And once they're settled, they're just a cosmetic problem, unless you have what we call a blind splint. And a blind splint is when the new bone grows inside, so you can't feel it very clearly, but it then rubs on the suspensory ligament. And you can see on this bone specimen here, that's where the suspensory attach, that rough area here is where the suspensory attaches. So you've got origin, body, branches, and then each branch then attaches onto the outside of those two sesamoid bones. The knee, or carpus, is a very complex joint. We can see on the bone specimen here, we've got this prominence at the back here. So this is the accessory carpal bone, and you can feel that on the horse, this knobbly bit at the back. And that's important when you're putting dressings on the knee, there's not too much pressure, because you get really nasty pressure sores over that bone. So if ever you're bandaging a knee, make sure that you sort of have not too much firm dressing. We take the dressing out of that little circular area at the back so we don't get rubs there, and keep a close eye on that. So you've got 3 levels of joints. This joint here at the bottom doesn't open up at all. That's a low motion joint, the carpo-metacarpal joint. So that just stays closed. The two other joints are high motion joints. So this is what we call the radiocarpal joint and the middle carpal joint. And the two lower joints communicate. So if you had an infection in the lower joint, it will get into the middle joint as well. But this is completely separate, this joint here. We rarely see problems in the knee in any horses apart from race horses. Race horses, we see it all the time because of the cyclical loading and the trauma. They get little chips of these bones and they get arthritis in the knee very commonly. But sometimes we see it in eventers because they're doing similar training at the higher levels. But we wouldn't often see any knee problems other than wounds and kicks in the knee. And this is a horse that got kicked. And you can see here the damage to the surface of the bone. We've got some lysis of the bone's been eaten away by some infection, and this is a tiny little bone here that's fractured, and that's the remnant of the ulnus. Then we come up, we've got the radius here, and then we've got a little bit missing here, which would be point of elbow and the ulna. So this is the ulnar bone. It's one of the more common fractures we see actually in the general horse population would be ulnar fractures from horses being kicked. And if you see a horse presenting not able to sort of walk on the leg and the shoulder is dropped, it potentially has got a fracture of the elbow, which can be fixed fairly successfully, and more successfully if there's not a nasty wound involved, if it's just a closed fracture. So the anatomy of the hind limb and forelimb from below the knee and below the hock is almost identical. In the hind limb, the cannon bone is a little bit longer than the forelimb, and the check ligament is much smaller in the hind limb. It does have a check ligament in the hind limb, but it's much smaller in the hind limb compared to the forelimb. If we just look at the hock bone specimen, again we've got low motion joints lower down. This is an X-ray of the hock, and again, if we were looking for signs of bone spavin, these are the joints where we would be looking. So we call this the tarsometatarsal joint and the distal intertarsal joint, and we're looking for narrowing of these joints, new bone formation at the margins, changes within the bone, sometimes getting denser, whiter appearing, or sometimes getting bone loss in darker areas. And then we've got the high motion joint just here. And if we've got OCD, we see flattening of these ridges and fragments within the joint. Bog spavin is increased fluid in this big joint here. So if you've got increased fluid in the tarsocrural joint, that's bog spavin. And you can remember that's boggy and soft versus bone spavin as these sort of the little joints where it's arthritic changes. This is the Stifle X-ray, so this is this joint just here, his knee, essentially equivalent to our knee. Here's the patella, and then we've got the tibia and the femur, the big femur. And again, this is where we see OCD in young horses, so flattening of the trochlear ridges, sometimes what we call joint mice, which are little bone fragments and cartilage fragments within the joint that need to be removed surgically if they're not going to cause lameness. This is the fibula, so this is the tibia, tiny little fibula compared to people, and that's not a fracture just there, that's actually just a bit of cartilage connecting the two parts of the bone. So they start their transformation into bone from cartilage at different points, so separate centres of ossification, and that's just the normal variation. And again here, this is just a young horse, and this is what we call separate centre of ossification. So that's not a fracture line, it's just the bone slowly growing out from different points and gradually maturing. So that's probably a yearling.